Perfect. Thank you very much, Dr. Dinesh, for this wonderful instruction course, which we are all learning a lot. So, OCT angio, I don't think I have to explain the basics because we have all gone over it so many times. But it's just that non invasive, no dye, and instead of seeing all the plexus merging into one another, as we see on fluorescein, here we see each plexus of retina, that is superficial, intermediate, and deep capillary plexus separately. So that helps us in better understanding. So how does it look like? This is what we look at the superficial plexus. This is how the deep plexus look. This is the outer retina, which normally doesn't have blood flow. And if you want to study the choroid, you go to the choriocapillaries. The key is that you have to put these lines in the area where you are segmenting it, and that is very important because whenever there is a pathology and your segmentation lines are not appropriate, you will not get a good information from each of these plexus. So Dr. Dinesh gave me a topic where we are currently applying angio-OCT. So I will start with the common disease first, which is diabetic retinopathy that we all see. So in diabetic retinopathy, as was mentioned by Prashant and Sangeet also, that macular perfusion is one of the key factors. And it's very useful in picking up the non-perfused macula to evaluate the FAS, and it can also visualize the majority, but not all the microaneurysms. So if you're planning to do a focal laser to the leaking microaneurysms, I would still go for fluorescein, especially if it is a repeat laser. But OCT angio can definitely detect other abnormalities which may not be seen on fluorescein, and we will go over them. Now, this is an example of FAS. This is the superficial plexus, like we are used to of calling FAS ischemic one when we see the irregularity, when we see the increase in the size. But if you do OCT angio, early changes are increase in the intercapillary distance in the superficial as well as the deep plexus would be the earliest sign that this is the patient who's going to develop or in the process of developing macular ischemia. Dr. Prashant said that he showed a case of CRVO where he had to repeat fluorescein angiography to see NVD, but probably you can see these NVDs very nice clinically, of course. And if you feel like documenting, angio-OCT again shows you very well these new vascularization because they do not leak. So you will be able to document them very well and follow them up for regression. Many times you may be confused, especially in vascular occlusion, whether what you are seeing on the optic nerve head is a collateral or NVD. And conventionally, we have been taught that you do fluorescein, collaterals will not leak, NVD will leak. But actually, you can differentiate the two on angio-OCT also. NVD is raised, and you will see in the vitreous frame, whereas collaterals you will see in the retinochoroidal phase. NVD can be seen on low resolution also, but for collaterals you need really high resolution 3x3. Most important use of angio-OCT is in the development, characterization, follow-up of choroidal neovascular membranes. So you may be able to identify type 1 membranes, which are just hidden behind the irregular RPE detachment, or a small type 2 membrane, which might be hiding somewhere behind the shrem. So I'll show you an example of this case. Like we see the patient, we do the fluorescein, and fluorescein in the late phase shows hyperfluorescence, indicative there is a membrane, which you can see is very well just in the outer retina doing an angio-OCT. thus avoiding the need for any dye injection. Now, these are the patients, especially the old patients, and you are following them up. So you cannot be time and again repeating the fluorescein whenever in doubt. OCT, of course, is a very great tool, but OCT shows you the fluid. So if you really closely want to monitor, these can be monitored just on NGOCT, and you can look for the pruning and persistence of the vasculature. Pruning is a good sign. It means the new vessels are responding, and you can actually start injecting when the size of the new vessels increases, even if there is no fluid on OCT. This is just to show another case, and this is where it is being very commonly used, patients of chronic CSC. So in some of these patients of chronic CSC, we were kind of injecting Lucentis or whatever anti-VEGF without even realizing why we were injecting. But now with the advent of OCT-angio, we have started identifying these small new vessels which are hidden and developing, lurking behind, I would say, underneath the chronic CSC, and that makes giving anti-VEGF so much sense in CSC. Because earlier it used not to make sense to me why treat CSC with anti-VEGF, but post-angiosity definitely, if I see these kind of membranes, I would treat. And you can see the patient of CSC responding, even the fluid is disappearing because this component had come from small vessels, and you can see the vessels reducing in size. Wide field OCT montage is extremely useful to pick up the areas of ischemia, even if you may not be able to see new vessels very clearly. So this is an example of a patient, occlusive vasculitis. The fluorescein, of course, is still beautiful, showing the vessels which are leaking. But if you are doing angio-OCT, the wide field, you can still delineate these areas of capillary non-perfusion and the network of abnormal vessels which can be treated. And this is the same post-treatment. You can see the laser scars, and you can see the area of capillary non-perfusion before and after the treatment. Leakage is a problem, and that is where you should not be relying on angio-OCT. So if you are actually looking for the peripheral vascular leak, the conventional angio-OCTs that we have, you can see here, they do not, like the left eye is showing the leakage, but macular edema is there, which you can pick up on OCT, and OCT is an integral part of angio-OCT. So you have to always see angio-OCT along with OCT. But if you want to pick up these area of leakage, you are going to definitely miss them on angio-OCT. However, there are now new methodologies like you can color code them. For example, red would mean these are the vessels which are having vasculitis, but these are kind of not yet commercially available. So we are going to reach a stage where we will be able to pick up the leakage on angio-OCT. Wide field is very effective in picking up these small granulomas, and this is the ICG that I am showing, but see the superimposition of angio-OCT. So to an extent, this angio-OCT can pick up
and you can monitor them.
Oh, sorry, this is the recorded one. I'm sorry.
The take-home message that I would like to get, that OCT angio is progressively reaching a primary position in the precise assessment of uveal inflammation. The potential development has not been completely explored yet, but fluorescein and ICG may be able to, we will be able to get them replaced, but their role actually has to be, we have to define their role very correctly. Thank you very much.